Hello everyone. It's 10 p.m. and then we have a new program that is Quiz Up lined up for you. And this is the alternative to your rapid quiz, which used to be at 9:30 before. 9:30 p.m. was the time. And now this Quiz Up is at 10 p.m., 10 to 11 p.m. This is a scenario-based, case-based learning. This is going to definitely make you think a lot and then answer. So you cannot simply just guess the answer. You will have to think, you have to implement the theory part to your practical, and only then you will be able to understand and answer the question. So because these are all case based, so you'll feel more like as if you're treating the patient. Okay, so this is a nice way to use your theory that you have learned. So this we have quiz up, that is first one today, that is the first part. Then we are going to have many sessions every single day at 10 p.m. from this day onwards. And myself, Dr. Rohini, and I have about 10 years plus experience teaching all the aspirants like NEET, USMLE, MCI, lab, etc. I have a whole lot of students who have studied under my guidance, and I have bagged very good seats at various prestigious universities. So I wish you all also get a very good, PG seat and excel. So to reach your goal, this is me teaching anatomy subject with a lot of clinical based questions at this time 10 p.m. every single day. You can follow me at RoAqua. You can also use this promo code ROHINI for YouTube users, and for special classes you can use ROHINI 10. This is another promo code. And if you are a regular visitor, you please don't forget to like the classes that we post, and also subscribe so that you don't miss any of my classes. You get notification for all the classes. That way you will not miss any of the classes, any of the case scenarios that we are going to discuss. So today some interesting things from CNS as well. So we'll do all that in a bit. Let's see if there is anyone who has any questions or queries. Okay. Just give me a second. The first question, we'll come back to this little later, but let's do with one or two questions and then we'll come back to that particular slide. There we are. Okay, all right. Sorry about that. First one, how is stellate ganglia formed? Anyone? Anybody knows anything about stellate ganglia? What is stellate ganglia? This is CNS. So if you are not aware about basic things, then it becomes very difficult. CNS is quite complicated, quite interesting as well. So what is stellate ganglion? What is it? It is from sympathetic trunk, which controls the muscles, smooth muscles. Any idea what is stellate ganglion now? How is it formed? So you can see that stellate ganglion, there is superior cervical ganglion, and there is this middle cervical ganglion and inferior ganglion is also known as stellate ganglion. We have a lot of students who are watching, but I would ask everyone to participate. Good evening, Rishabh. And, stellate ganglion is actually the sympathetic ganglion. It is formed by fusion of the inferior cervical ganglion. It's also called cervicothoracic. Okay, with the first thoracic ganglion. So these two fuse, this one and this one, they fuse. This is also called, first thoracic is superior, right? It's not inferior. This is inferior because it is the last one. So it is almost the last one with the first thoracic. So this is called inferior cervical ganglion. And this one is the first thoracic. So it is called superior thoracic sympathetic ganglion. So now sometimes it's not just first one, second and third also may join. They may join together. And that's how you get this stellate ganglion, which is a very important, which is a very important ganglion. Second and third also would join. So now here 80% of the cases may also have second and third ganglion joining them. So 80% of the cases you may see such a arrangement. So now here there are various clinical aspects associated with that. We will talk about it. What happens when we block the stellate ganglion? See, there are various instances where the stellate ganglion is blocked. Okay, so now here there is a phenomenon also where stellate ganglion is blocked, and then some of the fibers are cut and it is made less active. All this is done in various cases. We'll talk about it, but let's see some explanation on the same. There is this anatomy of the stellate ganglion. You can see that stellate ganglion is here, and it is an oval shaped 2.5 by 1 by 0.5 centimeters in diameter, and it is at the level of, now you know that it is inferior cervical ganglion, so it is between C7 and T1. Okay, this is the thing. So it is inferior cervical ganglion. So it is present anterior to the transverse process of C7. So if you see C7, just anterior to that, you will be able to locate it, but very close to the first rib and longest colli muscle. So this is where your location of the stellate ganglion is. It's a very important ganglion for various reasons. One is to do with those people who are dealing with the cancer. Then those who are with the sweating of hands. That is extreme cases. So in these cases, the block is given. So you should know where is the location of the stellate ganglion. So nearby structures, you can see the brachial plexus, you can see spinal nerve roots, you can see prevertebral portion of the vertebral artery also you can see, because we are talking about the cervical region. You can also see subclavian artery and cervical pleura because of the neck region. And cervical pleura extends above the first rib. That's okay. So with all this information, let's move to the next one. Here, there are various reasons for this. Now, there is one condition that is extreme sweating on the hands can happen. In this case, the stellate ganglion is cut to decrease the symptoms of this sweating of the hands. Now, here block is also given to reduce some of the conditions like hot flushes, night awakenings that is suffered by these breast cancer survivors, and also women experiencing extreme menopause symptoms. So for all these people, the sympathetic ganglion is excised, that is stellate ganglion is excised. Now what it does is, once you do that, it will reduce the anxiety and it will reduce the headache, migraines that is associated with the menopause, and also the cancer pain from these neoplasms. All that can be reduced by blocking and also by cutting the stellate ganglion. So now what are the complications of the block? Now I told you that block can be given, but at some places there could be a big complication that is known as Horner's syndrome. So Horner's syndrome could be one of the complication associated with the block from the stellate ganglion. So this is an important thing to remember. All right, next one. Okay, so now other than this, there is one more condition. I just want to highlight one more condition. This is of the previous slide. There is no space. So I have this small thing that I want to mention. There is a phenomena. Have you heard of this? Raynaud's phenomena. What is this? This is nothing but the sweating on the hands. So this is what I wanted to mention. So sweating on the hands. Is known as Raynaud's phenomena. And all these symptoms that is exhibited by them is all together, whatever the symptoms like sweating and then, not able to, hot flashes on the face. All this is a phenomena that is exhibited by Raynaud's phenomena. Okay, next question. We'll move on to the next one actually. So what is cyalolithiasis? Lithio is stone. Okay, it's a condition where a person has stone. Where it is in one of the glands. It could be, we talked about salivary glands in the previous class. So it is in one of the salivary glands. Almost all of them are prone to having a stone, but the stone present in the submandibular is a higher chance. Now, these stones are present more in this age group, that is 40 to 50 years of age, and recurrence of this stone is about 20%, and then they are usually asymptomatic, but sometimes they also may exhibit some things like swelling on the face. This could be one of the symptoms. And then they also may have some immunologic factors like inflammation on the face, dehydration, anticholinergic, calcium saturate. So because these stones are nothing but calcium stones. So these are calcium stones. They may also have magnesium. It may also have ammonia and potassium. But the highest amount is calcium. So they're made up of calcium stones, and it could be also associated with some bacterial infection. So these stones occurrences, 20% chances are still there even after removing the stone from these ducts. And they block the ducts and they prevent the saliva that is produced by these glands. Next one, let's enter the question itself. Okay, let's go to the questions. Now, there is a 24-year-old football player. He was taken, let me keep my phone, let me see who is messaging. Okay, there is a 24-year-old football player. Okay, he was taken to emergency room because he received a blow on the leg. Okay, and it resulted in pain and he could not stand up. And attending physician was able to locate a very painful area just below the knee. So below the knee. Okay. So now below the knee is what? Which bones? Tibia, fibula, one of these. Right? And suspected a fracture to be fibula. Okay, it is ruled out tibia. Now it is only fibula. He ordered an anteroposterior and AP and lateral X-ray of the leg and the knee joint. Now, a clear spiral fracture in the left fibular neck is found to be there. So, fibular neck fracture. And a cracked tibial shaft was shown on the X-ray. So, there was a hairline fracture here as well. The patient was given analgesics and thorough neurological examination was done to see if there is involvement of any nerve in this fracture, but no signs of nerve injury was detected. So he was fine. It was just the bone involved. A cast was applied and patient was discharged. Now, how do we discuss this particular case? Now, what is that? The upper end of the fibula fracture or fibular neck. Now, fibular neck is what is fractured and the shaft of the tibia is what is fractured. How do we discuss this? Okay. Now, what are some of the questions that we can ask ourselves? Now that they said that nerve is not injured, so they were looking for which nerve? Which nerve they were looking for? Anybody? Anyone who wants to answer which nerve they are looking for? So there are so many nerves. There is the sciatic nerve, which divides into tibial and common peroneal. So common peroneal is what goes towards the fibula. So they are looking at the common peroneal nerve in such incidents because it is quite superficial. So there are chances that it will be injured, but in this case, it is not injured. It is not touched. Next, what would the doctor look for to confirm the nerve injury? What he should look at? Which of the two injured leg bones was primary factor in the patient's inability to walk and why? Then what problem may be encountered in tibial fracture? So these are some of the questions we can ask ourselves. Let's see what are the answers. So now first one I told you, it is the common fibular nerve, which is also known as peroneal nerve. It supplies the lateral and the dorsal compartment. Next one, what kind of action is lost? Because lateral compartment, eversion is lost. This is done by lateral compartment. So eversion is lost. And then there is dorsiflexion because it's supplied by the dorsiflexion is done by the dorsal compartment. So that is lost. Lateral compartment is supplied by superficial branch of common peroneal. This one is supplied by the deep branch of common peroneal. So that explains the loss of motion. That is eversion and dorsiflexion. The foot drop is usually a result of this injury, but this cannot be confirmed so early because the accident just occurred. It takes some time for the foot to show some symptoms. So now tendon reflexes could be very weak and there is lot of sensation, loss of sensation also on the anterolateral aspect of the leg and the dorsum of the foot. So cutaneous supply is also damaged. Next one, the principal bone that is weight bearing bone where the muscles are attached is tibia. So the primary bone that is injured, that is taken into account here is tibia. Now, the last question said, what problems may encountered in tibial fractures? What problems can you see if the tibia is fractured? Is it a big thing or it's a small thing? So one is it is non-union, nature of the tibia. Tibia doesn't easily, all the leg bones for that matter, compared to the upper limb bones, the leg bones are the ones which usually does not cooperate and the union is not possible. So non-union nature of the tibia. So this is one thing that can really bother the patient. So it crosses nutrient canal. If the nutrient fracture crosses the nutrient canal and damages the nutrient artery. So nutrient artery, what is the direction? What is the direction of the nutrient artery? It is away from the knee, I flee. So it is away from the knee direction. It is towards the ankle. So if the fracture is near the shaft where the nutrient artery is moving away from the knee and towards the ankle, then there are chances that it may not heal at all. And since tibia has relatively poor blood supply compared to the fibula, the fracture of tibia takes longer to heal. And as it is, the non-union nature of tibia is negative thing that you can think of, and blood supply of tibia is low. That's one thing to remember. Sometimes up to 6 months, the person may be in cast. So this is the nature of tibia. Okay, next one. Next question. A 28-year-old volleyball player, he fell on a right outstretched arm during a game. So she fell on a right outstretched arm. Okay, just imagine this. You have to learn to imagine the scenario questions. Only then you can get it right. She felt an immense pain in her wrist. So this is where she fell on her wrist. And orthopedic surgeon at the emergency room said that there is deformity in her right wrist similar to dinner fork deformity. So which bone do you think is dinner fork deformity involved with? In dinner fork deformity, we usually refer to the radius, right? So all wrist movements become very painful. And then a pain radiograph revealed that a transverse fracture of the distal end of radius. Distal end of radius because that is where the wrist is. And radius is the bone that forms the part of wrist joint. Okay. Next, it was tilted backwards. It was tilted backwards and radially. And case was diagnosed as the Colles fracture. So dinner fork deformity is seen in Colles fracture. So if there is no dinner fork deformity and if the fall is on inward moved wrist, then you call this as Smith fracture. You remember the I for inward, okay? So colis is outward stretched hand, outward. So these are the two fractures, both of them with the radius bone. It takes about 6 to 8 weeks to come out of the cast. So this is one case scenario where we can discuss about various. Okay, let's go back to the previous slide, one slide where I wanted to give you little information on the offers that we have. We have a lot of offers. One is the limited time offer we have for the PG NEET iconic subscription. So we have iconic subscriptions, that is with the plus classes. We have access to two best learning platforms, that is not just an academy, for the prep ladder as well when you have this plus subscription. And that is a good news for you because you have both the platforms. You can access, take a subscription at Unacademy. You also access the prep ladder classes. And the month, 36 months you have, before it was 92,000, now it is reduced to 58,500, and then it inclusive of the discount you get this much. You can use this code icon 10 to get limited time offer discounts, and then it is for the first come first serve, first 500 students only get this offer, and then others would have to pay the 90,000 fee. So it is better you decide faster. Then 24 months 77,000. Again, it is reduced to 49,500. And 18 months, if you're thinking at now think that you're in second year, you can go with this 36 months because you will not just excel in your UG, that is second year, third year, but you will also get a good tuition of all the subjects, and that is just for 58,500. Otherwise, you will not be getting the good base. You'll not be getting good basis. So it is very important that UG basis is also good, right? So if you are in your second year and planning to prepare for your NEET PG from now itself, then go with this 36 months and above. And then 24 months, it is 49,500, 18, it is 45, 12, it will be 4,500. So there is a lot of reduction in the amount. You can see up to 10,000 plus there is reduction once you use this code icon 10. So use this code and then get the reductions and avail discounts. And this is a good news that you also get to access the prep ladder classes along with the Unacademy. So lot of educators, lot of motivators for you to crack your NEET PG. So go look at it. And then you also have this, that is, if you buy 3 subscriptions today, 3 months subscriptions today, you get fourth one free. That is, within 30 days, it will be added to your subscription. So by the end of the first month itself, you will get the fourth subscription added to this. It's an amazing offer to try if you're very close to your exams and don't have so much time to go for a year-long subscription. So now these are some of the, NEET PG seasons batch is going to start. That is from 2nd June, that is tomorrow. So hurry, and you have discussions, and then high yield topic revisions are present here. And then you also have interactive classes and maximum questions and answers and focus on integrated learning, clinical, everything is done by our well-known educators. So go for this and you get lots and lots of ideas and guidance to clear your NEET PG. So we have all these educators who can guide you. So we'll go to the section where we left. Okay, now here some of the questions that we want to answer regarding the previous question. Regarding the previous question, I just mentioned that there is this Colles fracture, it is outstretched hand. Now, outstretched hand I mentioned, and then it is also the extensor tendon that is injured. Which one is the most likely extensor tendon that is injured? That is extensor pollicis longus. Pollicis goes to the thumb. And this is on the radial side. Next to this, there is this artery also, radial artery. Extensor pollicis longus. There is one more called extensor pollicis brevis. So these two are also part of the anatomical snuff box. Very, very important slide. Very, very important line to remember. So, in Colles fracture, which muscle tendon is more likely? Remember, anatomical snuff box has the boundaries, right? In the boundaries, there is only a loner tendon on one side. There are two tendons on the other side. Which is this loner tendon? It is extensor pollicis longus. Which is this one? Brevis. Which is the other one? Abductor. Abductor pollicis. Which is this one? Extensor pollicis brevis. So you have to remember the lonely tendon is longus. Okay. Next, what would be the complication if such a fracture takes place in young children? So in young children, if Colles fracture takes place and if the epiphyseal plate is damaged, because epiphyseal plate is there cartilaginous, it is not bony. It is there near the wrist. That wrist is where you can see the epiphyseal plate. And if that is the thing, then if it gets crushed, then what is the thing? Then there is in this case, a differential radial and ulnar growth may result, and there could be a deviated hand. The hand could get deviated hand. So this could be one important thing to discuss. If it happens in the young children, there may not be proper reunion, and that could result in the hand that is not straight and it is deviated. What is the basic principle of treating a displaced fracture in this case? So now here, if the fracture is displaced, is it the distal end of the radius in one piece, or if it is fragmented? If it is fragmented, under general anesthesia, fragmented pieces are taken and it is impacted by traction. Screws and plates are fixed, and then it is firmly held in place. Now the lower radius, now you should maintain it is reduced first, and then the plaster of Paris is applied, and then it is kept in that position where it is flexed, pronated, and in ulnar deviation only. Not because there is always a tendency to go for radial deviation, but it is pulled and kept in ulnar deviation. Okay. So now post X-ray reduction at 1 week, and then there is removal of plaster at 6 to 8 weeks. All this is done in case of displaced fracture. Next one, let's see the question. These questions are lengthy because it involves the scenario. So you have to imagine the scenarios. So now here there is a 5-year-old female, a small girl, and she was colicky and there was pre-umbilical pain. It got very bad. It got intensified about 6 to 8 hours in the past 6 to 8 hours, and started to migrate to the right lower quadrant. Okay, it started with the umbilical and then went to right lower quadrant. So right lower quadrant, what do you think is present? Right lower. So you think of all those, you know, you can think of all the four quadrants. There are four quadrants: right upper, right lower, left upper, left lower. What areas are there? There is appendix is there, and then there is the ileocecal valve, cecum is there, right? All these are present. You can think of one of them now. The patient reports some initial nausea and there is increased pain. The vomiting is there, anorexia is there, and patient has no distension. Auscultation reveals that there is a hyperactive bowel sounds that they can hear in this side. And there is tenderness and muscles of this anterior abdominal wall on the right lower quadrant has become very rigid, and patient has low grade fever as well. That means there is an infection, right? He has fever as well. And there is laboratory test that reveals white blood cells count is increased. That means there is infection confirmed. Then they have to take her to the student to operating room, and the result is appendectomy. So with list of things, you have to arrive at the conclusion that it was the surgery for appendectomy, because I mentioned here she is a young girl. So it has happened with a young girl. That is one thing to note. And then another one is colicky, and it started from umbilical to the right quadrant. So that is McBurney's point, you have to remember. And it is on the right side. Remember. Next, what you can think of. Auscultation reveals hyperactive bowel sounds, and then there is fever. So you know it is infection, and it is on the right side. Think of all the things on the right side. And blood cells, WBC, lab test, everything is pointing towards the appendicitis. So appendicitis, and it has to be removed. So appendectomy surgery was done. Let's see some of the questions that can be asked in this situation. Now, first of all, what is McBurney's point? It is a point from the right anterior superior iliac spine to the umbilicus. That point connecting these two is known as McBurney's point. And tenderness at McBurney's point always indicates to the appendicitis. And then the patient had all these things. Now, what sign and symptoms revealed physician that he had to go for a potentially appendicitis? Is the symptom, is the conclusion, because she complained of abdominal pain, anorexia, nausea, vomiting. All these indicated that it is appendicitis. But how do you think it is appendicitis and not gastroenteritis? Because there is a difference. Gastroenteritis is also an inflammation. Appendicitis, this was on the right side. That is one thing. And this one, she kept on mentioning from the umbilicus to right side. Correct? That is one indicative of the appendicitis. If it was gastroenteritis, that would not be the case. Another one is it causes vomiting and diarrhea. But will also present less acute history of abdominal pain. So now here in this case, diarrhea was not there. Okay, so that is one thing. The right side, diarrhea. These two is one indicative of finding a difference between gastroenteritis and appendicitis. And also the abdominal discomfort is more in appendicitis than the gastroenteritis. Okay. So if you go to the history, you can check how many times the girl was complaining of gastroenteritis and was it cured or it was recurred, recurrent episodes were present. All this could be checked for. Next one. A 40-year-old woman who works as high school teacher, she reported to her, she is 40-year-old. She has, school teachers usually stand for long hours, right? They stand for long hours. She reported that she has varicose veins in both the legs. And she, see, all, you should also consider what kind of their work profile is. They most of the time sit and stand, but not less walk. Walking is less. So she has pain and swelling both the legs, and it will get worse, particularly at the end of the day because of long sitting and standing nature of the job. Pain is relieved when she raises the leg on the desk at home, but she cannot do at her workplace, right? She wears support stockings, exercises would be helpful, but condition is becoming more and more worst. And then physician examines her and excluded deep vein thrombosis. He suggested lower limb venography and surgical management at the hospital. See, usually deep vein thrombosis is again because of long flight journeys and also because of less usage of skeletal muscles. Limb muscles we are talking about. So this is what happens. Deep vein thrombosis, you call this as DVT, right? DVT is for deep veins and varicose veins is with the superficial veins. Which are the superficial veins? Great saphenous vein and lesser saphenous vein. Next, what are we going to discuss in this particular slide? We can say that lower limb veins are most likely to become varicose. Why? Because we have the superficial veins and that is great and lesser saphenous veins and their tributaries. So these are the ones which carry blood against the gravity. So that is one thing. So it requires effort always. And if the valve is not competent enough, then there is a chance that the veins can become thrombosed. So that is one thing. What are perforating veins? What do they do? The perforating veins are the ones which connect the superficial veins to the deep vein. Sometimes these perforating veins may not be competent enough and blood from superficial may not be running to the deep veins and this can be varicosed. And calf muscle plays an important part in, it is a skeletal muscle. Calf muscle is gastrocnemius. It's an important part for, pushing the blood against the gravity. So here what happens? There is something called peripheral heart. It acts like a peripheral heart. That is gastrocnemius plus soleus complex. These are the skeletal muscles which help the blood to go against the gravity to join the deeper veins like femoral vein. Now, why do varicose veins develop first of all? That is the blood that is directed from the superficial to deep veins, perforating veins do that. So now here, sometimes the deep veins are surrounded by, you know that deep veins are surrounded by the muscles and they have valves as well. But as the muscles contract, now you know that the skeletal muscle contraction is the key thing for the blood to move from superficial to deep. So now here, valves in the perforating veins, they prevent backflow of the blood. When valves in the perforators fail, the valves may fail sometimes. They may not be competent enough. That time, the blood from the deep structures is forced into back into the superficial veins, and that because of the hydrostatic pressure and the blood being forced by the muscles back into the superficial veins, it can undergo varicose. So valves are incompetent. So what happens from deep? It goes backwards to superficial, even though there is a valve, because valves are incompetent. So this is what happens. So if the skeletal muscles are strong enough to push the blood against the gravity from superficial to deep, then it is possible. The muscles are also not strong enough and these valves are also not good enough, then it can happen that from deep the blood can move to superficial, and that results in varicose veins. Now here, all these predisposing factors you can consider, prolonged standing you can consider, then what surgical options are available for treating such varicose veins you should think of. There are a lot of treatments, including some in some countries they use this leech leeches, and they also use injecting some sclerosing solutions into the vein so that it is ligated, stripped, and also it is the blood inside is thinned. Some people also use ecosprin. All these things are used to ease the flow of the blood. So again, it depends on the physician. All right. So now here we have the next and the last question. And here it says, a 24-year-old man was refers to OT with a suspected intramuscular lipoma. In the right upper thigh. Lipoma in the thigh region. It was visible on medial portion of the thigh. Which side? Medial. As a soft mass. Surgeon also noted a shallow triangular defect apparently in a musculature lateral to gracilis muscle. Gracilis is the medialmost muscle in the medial compartment along with the adductors. Plus the adductors are the medial compartment muscles. So he noticed a shallow triangular defect in gracilis muscle. And when patient was adducted the leg against the resistance, the mass became even more very prominent and firm. So CT scan and other things revealed that it was not, adipose tissue, but it was a muscle mass. So now, upon questioning, the patient later said, patients don't tell things at once. They will tell you, only when questioned. He sustained an injury to the medial side about 1 year back. And then when he did that, when he was playing soccer, and then in the opposite direction, someone came, hit, and then it felt sharp pain immediately in that thigh region. But after several days, when the pain went down, he did not bother and he did not go to any physician. Now, needle biopsy was done. It showed that the muscle tissue was normal, but patient experienced very discomfort because it is on the medial side and it makes the person difficult to walk. So what do you think is the thing? Is it what it is? Is it a lipoma, they say? Intramuscular lipoma. What do you think the mass is? Which muscle do you think? It is one of the muscles of adductor because adductor gracilis has become thin. Gracilis is thin and dented. Because of which muscle? Because of the adductor magnus, which is overriding. It is overriding this muscle. So based on the location of the mass, you must remember if the gracilis muscle mass is reduced, obviously it is because of the adductor magnus muscle. And it was probably the adductor longus also. So what do you suspect happened to the cause of the mass in the first place and why was it growing first of all? So now the bone muscle mass resulted when tendon of adductor longus was avulsed near the bone from soccer. So you know that this is the one whenever in games like kicking or when legs are apart, this muscle undergoes strain. Okay. So in this case, what has happened? It has lost or there is a avulsion near the insertion of the adductor longus. Now, this tendon allowed the mass to retract. So what happened to adductor longus? It got retracted. It formed a abnormal bulge. So when there is a origin and there is a insertion, if this is cut off, then this will simply contract and it will form a rounded structure. That is the mass that has happened. Now here, as the injury healed, the muscle, instead of reattaching back into the femur, it started growing in a circular mass. So the hypertrophy resulted as a growth of mass in the medial side of the thing. So now adductor longus is the mass and gracilis is thin because adductor magnus muscle is pushing the gracilis and reducing the density of the muscle mass. So this is how you are supposed to come to the conclusion. So with all these things, I hope you are able to think in the terms of, diagnosis and treatment. And I hope that you have understood what we are talking about. So many case scenarios we talked about. We talked about the lipoma, we talked about the appendicitis, we talked about various aspects. So it's very important that you learn case scenarios and come up with various questions. Now, each scenario based question has some one, two, two, three questions, and each one is important because it will give you a clear picture of what exactly is the situation, and then it will give you time to think what could be the reason. So if you are aware of what are the muscles on the medial compartment, then it is very easy for you to answer the question. But for that, you have to have theory very strong. So your theory has to be very strong. So always go for some theory topics to read up and then try to solve the questions. So that will help you in solving more questions than what you can otherwise do. Okay. With all this, I would like to thank everyone who attended, and me, Dr. Rohini, signing off. Please subscribe and follow. Also subscribe, and you can also look for my special classes on that is again a topic based class, and then you also have some plus classes. So all this will be there in the evening hours only. So look for all this, and I'll see you in a short while. That is tomorrow at 7 p.m. with a new topic. And then again, that is again a histology topic. Now, today's histology topic was on salivary glands. Please go look for my classes on YouTube. Today's topic at 7 p.m. was uploaded, histology of the salivary glands, lot of clinical studies and what is the difference between each type of salivary gland in histological sections is uploaded, very neatly explained. So go watch it, and please like and subscribe, and look forward for tomorrow's 7 p.m. and 10 p.m. class. This is important, and 10 p.m. is always a quiz type session. So me signing off, and you all have a good night.